Doctors of Medicine. So today we continue with our embryology playlist. So this is the last video of the embryology of the digestive system. So in the previous videos, we spoke about development of the foregut, development of the midgut. Now we're talking about development of the hindgut. Summary, we say that the artery of the foregut is the what? Is the celiac trunk, the midgut, the superior mesenteric. Now, the artery of the hindgut is the inferior mesenteric arch. Okay? We need to know that. And remember when we did the video on the midgut, we said the midgut extends to what? We said the proximal 2/3 of the transverse colon. So the hindgut is going to be beginning on the distal third of the transverse colon, the descending colon, the sigmoid colon, the rectum, and then it's going to only contribute to the upper part of the anal canal. Upper part, not the lower. Okay, the upper part. Okay. So we are saying that the inferior mesenteric artery is only going to be supplying up until the upper part of the anal canal. That means the lower part is going to be having a totally different blood supply because it's not hindgut. Okay, very good. And also part of the lining of the urinary tract actually comes from the hindgut apparently. Okay, so now in this diagram we are seeing that this is our gut tube. Okay, remember this is the distal end of our gut tube that we have been talking about when we spoke about the development of the midgut. Okay, so here we see that the gut tube is going to come and is going to be ending into a blind pouch. Okay, this blind pouch where the gut tube is going to be ending, we refer to it as the cloaca. Okay, that is the cloaca. And then we are going to be forming a diverticulum which we refer to as the allantois. And then we spoke about it being extended by the urethra. Okay. Now the hindgut is going to also be joined by a mesentery. Okay, there is going to be a mesentery joining the hindgut to the what? To the posterior abdominal wall. And in this mesentery, this is where you're going to be finding your inferior mesenteric arch, which is your arch of the hindgut. Okay. So there are a few things that we need to note. Okay, because we are going to be having this gut tube is going to be ending in the cloaca. We have also two mesonephric ducts. Okay, so those two mesonephric ducts are going to be also ending into the cloaca. So this makes the cloaca a joint ending. Okay, whereby the urogenital system is going to be ending there, the digestive system is going to be ending there. Okay. But we know that that is not the normal arrangement that we see. There are two separate openings for that. Okay? So what happens is during the 7th week of development, here, if we look here, we are going to be forming, we have got the mesenchyme that is proliferating and it's coming to try and to separate it's trying to separate this gut tube into two. Okay, we call it the urorectal septum. Okay, the urorectal septum. So it's going to be moving until it separates completely the hindgut from the uppergut. Okay, here. So we see that here we have already completed the separating of the allantois. Okay, so the area that is it's going to separate it into two. When we have separated, we have the anterior area is going to be forming the urogenital system, and the posterior is going to be forming the what? The anal canal. Okay. So if I was going to take a transverse, to take a cross, we are going to be having something like these two openings. Okay. So that mesenchyme that's going to be separating these two is going to be forming something that we call the perineal body. Okay. This is the perineal body, separating the anterior being the urogenital, the posterior being the anal canal. Okay? Now, we want to focus more on the anal canal, right? So, we need to know that the anal canal is not opening on the outside, okay? So, it's ending on the inside, okay? So, there is still an anal membrane, okay? The anal membrane that's going to be covering it, okay? So it just does not lie in the rich communication in the outside. So we realize that around the 8th week of development, we have got proliferation of the ectoderm that's outside the ectoderm that's going to be moving inwards, invaginating up until it's going to come and it's going to be fusing with this hindgut, forming a complete anal canal. And this happens in the 8th week of development. Okay. This ectoderm that's going to be coming to fuse with the anal canal, we refer to it as the proctodium. Okay. So the word proctodium comes from Greek word which called proctos. Okay. Proctos means the road or the way out. Okay. So it is the way out of the anal canal. That's where the word proctodium comes from. Okay. So in the 8th week, you have got that proctodium coming in, and it comes in and it's going to fuse with the anal canal, completing the tract. Okay. So here's what I want to look at. Us to look at. Okay. We have got this blind part of the hindgut. Okay. And then imagine that this is the outer surface. So you see there is a space between the hindgut and the outer surface. And this area is ectodermal, okay? And that's where we're mentioning that this is the what? The proctodium, okay? So we are going to be having the ectodermal cells. The ectoderm is going to start to invaginate inwards. And there's going to be fusion. There's going to be fusion between this region of ectoderm and the hindgut, okay? And then the area where they fuse, this region over here, okay, is going to be forming what we call what? Our pixnate line, okay, or the white line, okay. So this is where we have transitioned. If you remember, we said that the epithelial lining, the GIT tract, is going to be coming from the endoderm, right? So this is where we are going to be having the transition from the endoderm to the ectoderm, okay. Also transition from the columnar epithelium, right, to stratified squamous from the ectoderm. This is where the transition is going to be. Okay. Few things to note over here. If a person, okay, here we are going to, so that means we are going to be having varied supply of blood. This area, the upper half of the anal canal, is going to be supplied by the inferior mesenteric artery. Okay, going to be supplied by the inferior mesenteric artery, and then this area is going to be supplied by the inferior rectal artery. Yeah. So this inferior mesenteric artery is going to be giving the superior rectal artery for this section, and then you're going to be having the inferior rectal artery coming from the internal iliac artery. Okay? So the blood supply is now different. Okay? Even also knowing that the nerve supply of this region is going to be autonomic. It's going to be having an autonomic supply. This one is going to be having a somatic nerve supply. Okay? So if a person has got cancer, right? Cancer, imagine that the cancer of the anal canal is lying in this region. It's going to be a painless cancer, right? But if the cancer is on the lower half of the anal canal, the somatic region that can feel pain, it's going to be a very painful one. We need to know that, okay? So now that we have discussed the development of the hindgut, we have said that we have a blind pouch which you refer to as the cloaca. We have said that we have formation of that urorectal septum that's going to be coming to separate the hindgut from the allotrace, and it's going to be creating what? An anterior urogenital sinus and a posterior anal canal, right? And then we are saying that we have the proctodium, which is going to be fusing with the hindgut to complete the anal canal around the 8th week. We have completed the development of the hindgut, okay? Now that we have completed this development, the question is always, what can go wrong, okay? So, I will mention a few of the anomalies that can occur, right? So, we have got this artery right here, okay? Here, this region is a site of portosystemic anastomosis, okay? So this is a site of portosystemic anastomosis, okay? That means if you have got liver cirrhosis, we are going to be having dilatation, okay? Dilatation here of the blood vessels over here in this region, of the anal region, okay? And you can see that distension or the varicoses in that region, okay? because there is photosystemic anastomosis. Number two, we can be having, okay, we say that we are at this stage, we've got the hindgut. At this stage, we've got the hindgut, but there is still a space between the hindgut and the outside, okay? We can have something that we call imperforate anus, okay? And imperforate anus, we are saying that the anal membrane has not separated. There is still that anal membrane, okay? This is why doctors will often check if the child has passed out to maybe 4 or 5 hours after birth to check if this anal membrane has not separated. But this is a very simple thing to treat because surgically this can be open, okay? So we need to know that. We can also be having something that we call anal stenosis, okay? So in anal stenosis now, we can, it's this canal, imagine that this is the anal canal. It's going to be having a very, very narrow opening, okay? A very narrow opening to the outside. And this is going to be causing a lot of difficulties, especially when passing out the stool, okay? You can be having this anal canal being joined to the bladder, okay? Which you call the urorectal fistula, okay? Joined to the bladder. Imagine that it's joined to the bladder. That means the stool is going to be passing through the bladder, it's going to be passing through the urethra. That's the process, okay? Instead of the normal, okay? We can even have something that we call an ectopic anus. In males, this ectopic anus is going to be found at the base of the scrotum. Okay, imagine. Okay. Now we can also have, so this opening can occur at very different areas. Okay, you can be having it as the recto-urethral fistula, and it's opening the rectum and the urethra. It's going to be the recto-vaginal in females. Those are different kinds of variations of this. Okay, so or atresia, yeah. Or we can also be having something whereby this anal canal is going to be not opening on its natural position, but it's going to be opening on the perineal body, rectoperineal fistula. Okay, so that opening on the perineal body is going to be small because the perineal body was not designed for that. Okay, and there are going to be difficulties in passing out the stool. So this has been the complete outline of development of our GIT tract, from development of the foregut, the midgut, the hindgut. We have spoken about the differences in the blood supply, the derivatives of all different parts of the GIT, and the different anomalies associated with all parts of the GIT tract. So this has been a pleasure. Stay tuned for more.